Sure. Awesome. Thank you. It's always a great pleasure to be at events, especially organized by you. It's my great honor. Thank you for having me. It's great to meet everyone and to give a small presentation following great speeches just before me by Nicole, by Jan. I hope that I will not repeat the things that you've heard that were great and were very important for us to know. I would like to focus on several things regarding healthy longevity medicine from the perspective of a physician, both longevity physician and a physician still, and hopefully always in a university hospital setting with a sick care. So myself, I split myself between sick care and longevity, but also between China and until recently Switzerland. Now that will probably shift to Israel. And in my talk, I would like to briefly go over a few things. Over the definition of healthy longevity medicine. We are always talking about longevity medicine or healthy longevity medicine. How is it actually defined? Then to talk about what we are trying now to do with Healthy Longevity Medicine Society, which is actually creating recommendations, evidence-based recommendations, experts' recommendations, and ultimately guidelines and quality control. Finally, also to go over diagnostics, longevity diagnostics already applied in the longevity settings in academic hospitals and in public health. And then to go over longevity protocol with a special attention on brain longevity, neurocognitive health, and then go over to the topic that I'm so passionate about, which is longevity medicine education for physicians, but not only. So we'll talk about that. So always I'm opening with this slide, and I probably will continue. And whoever saw me talking to this about longevity medicine before have seen this. It's because I finally understood in longevity medicine the quote from Alice in Wonderland that you have to run double as fast in order to move from one place to another. It was this famous scene. They were running, and they stand, and Alice asked, why did we run so fast? We are in the same place. The Queen said you have to run double as fast to actually move forward. And I think longevity, especially longevity physicians, but of course everywhere else, longevity medicine is one of the most inclusive interdisciplinary field, scientists, AI, computational sciences, and so on. But I think we have to really run double as fast to actually move this field forward. And in the recent years, for good or for bad, thanks to different sources of information, our patients, I call them patients, but healthy objects, healthy subjects, are requiring, are inquiring, are demanding information from their physicians. And this is why also we have this responsibility, I guess, and accountability to credibly give answers and at least to triage what is safe, what is evidence-based, or what is good to know, but potentially just be a part of a pool of longitudinal data sets that will be evaluated further. And in early 2020, actually in 2019, in Nature Aging journal, we were trying to give an early definition of longevity medicine, which there in collaboration with Professor Alex Zhavoronkov, who is the founder of CEO of In Silico Medicine, and with Dr. Kai-Fu Lee, who is like the godfather of AI, we defined longevity medicine as AI-powered precision medicine. So a branch of precision medicine that is focusing on health span and lifespan and is driven by AI tools, which we found at that point of time was quite a comprehensive formulation. Over the time, the longevity medicine field was infiltrated by some other information, not always very credible. Therefore, there was a need to create a medical society, just as you know, for example, ASCO, American Society of Oncology, that also cardiology societies. There are medical societies for specific fields in specific countries or global ones. And we thought there is a need of such a society for healthy longevity medicine or for longevity medicine. And when the council met for the first time, we really spent several hours thinking about the best definition that will include everything that we want to do and aim at in longevity medicine. And we came up with this. We said longevity medicine should be called healthy longevity medicine, and it is focusing on optimizing health span by targeting age-related processes along the entire lifespan. This gives a comprehensive overview over what we want to do, is not restricting in ethnicities, biological sex, age groups whatsoever, and is really focusing on optimization of the health span rather than punctual targeting of, in a reactive setting of fixing problems. And that's the Medical Society, as you can see here. So myself and Professor Andrea Maya from Singapore, we were the co-founders. She's the current president, I'm the vice president. And we have a great executive committee where you can see Professor Nir Barzilai, Professor Harold Pincus, the chief of psychiatry at Columbia University. So you can see brain was very important for us. Professor Thomas Rando from Stanford and Professor James Kirkland from Mayo Clinic. And we have created the website, and until now, without much promoting, we already have around 200 members. Almost 70 to 80% of those are practicing MDs. And that was very important for us. Now, what do we want to actually achieve with the society? We want to primarily create healthy longevity medicine as something that stands out as a separate discipline or as a sub-discipline of internal medicine, but definitely is a discipline. Why is that important? Because at the moment, everybody can just go and say, I'm a longevity physician. There is no certification, there is no diploma, there is no specific training, there is no quality control medical council that would approve such a definition of a person. Therefore, and I include myself in that, I would prefer to have somebody who would actually test me and recognize me as such, right? So this is our goal. And how do we get there? It will take some time. We are working with medical councils, with also, of course, other organizations that are in power to approve such a movement and approve such a physician, for example. So this is not only WHO, but also the ICD coding, part of WHO, and other medical agencies, including the FDA. And of course, we are also always in contact with various providers of the tools, of the diagnostics, of consumer organizations, governments, stakeholders, and of course, insurance companies, because ultimately, if we want, somebody asked the question, how do you bring it to the public? How do you implement it to public health? One of the main ways there is actually to work with insurance companies. And one of the mission, or some of the 4 missions that we created as our strategic points for the first 5 years, very Chinese 5 years plan. So we wanted to focus on education. We wanted to focus on professional standards for those doctors who are already practicing. We wanted to have a very clear agenda to promote clinical translation of the research into the practice for longevity medicine, and of course to work and establish more collaborations and strong collaborations with international entities that are involved in creating medical disciplines. And just to mention, of course, we are writing white paper, so hopefully soon you will see the white paper discussing the definition. You will see soon coming up also a paper on how to establish healthy longevity departments in public academic hospitals, and several others talking about supplements, geroprotectors, vocabulary of longevity medicine, standardized linguistics, stem cell therapies, etc. We are also working on the framework and guidelines. In order to get into guidelines, we first need to know how to make guidelines for a specific discipline, then to make recommendations, all the levels, A, B, C. So you will then go with expert recommendations and ultimately, hopefully, very soon arrive at guidelines for different diagnostics processes and also interventions. At the same time, working on certifications, it's very important to have well-trained physicians in the field. And what we are also already currently implementing for our members, for the MD practicing members, we have monthly case report sharing. We found that there is a niche, that there is a need to collaborate, to talk patients' cases through, more as a discussion. That's why we don't call it case reports, clinical cases. We call it case sharing, where we can judgmentally free discuss what we actually do, why, how, and so on, and what is especially identifying the gaps which are about to close. Now, as I mentioned, we also have a movement that is very heartwarming, which is development of longevity departments in public academic clinics. The first one was opened in Sheba in Israel, in Tel Aviv, in the Tel Aviv University Clinic, and also at the same time around in Singapore, at the NUS Clinic of Alexandra, and next year in Mayo Clinic, there will be also such a department open. And all of those clinics, and hopefully there will be more and more, and actually university clinics are reaching out, and we are helping them also to establish their own programs. We are focusing on having some sort of standards in order to use at least similar protocols for diagnostics and interventions, so we can better compare them, to actually then be able to combine those data, to verify them together. So as you can see here, we are extremely collaborative, and it's very important. We see the need, we understand that, and we do that. And of course, for this, we will need AI, so we work with people who can help us then to verify those data. And ultimately, of course, we will, and we are already conducting a bunch of clinical trials on interventions on those people. Longevity medicine is very much a global movement. As we know, those clinics that are being opened are all over the world. It is truly a global movement, and it's important, therefore, to really have quality control, not only for the doctors, but also for the clinics, and that's one of the things that the society is also working on, together, of course, with the governmental officials and medical councils. Another thing that I just wanted to mention, I don't have time to go into it, but I just had 2 days ago a conference of the McKinsey Health Institute, and we were discussing also with people who are in the field, Dan Büttner from Blue Zones and many others, how to build a better framework to develop healthy longevity cities, what is needed. And luckily, there is actually quite a bit of groundwork done. The strategies have been developed. It's just now only how to implement those. And it's very important to know that it's a very nice flow. The moment that Healthy Longevity City starts to understand that it's a PPP approach, it's a partnership of person and public, rather than imposing something. No, do not force people, facilitate in the background and digitalize. This is the way how we can achieve healthy longevity cities, because also those trackers and biomarkers and some of the interventions are really cost effective, and longevity dividend can be calculated very easily how much savings the city has then on the comorbidities. So, going back to the longevity medicine as a field, we know that in our regular sick care patient journey, we have people being born, reaching the so-called peak optimal performance or individual peak performance. It's usually a very short time frame, and from that moment on, we accumulate our age-related problems, optimally without diseases, but very often with diseases until the decease. And then in this time, we are usually led by several experts, doctors, with human limitations on how much differential diagnosis can be made. And most of all, we are being measured by frames and ranges that are normal or abnormal, or in ranges that are based usually on chronological age, rather than on biological age, which is what the healthy longevity medicine is actually doing. So we are trying to bring back the patients at a specific point of time in a specific life situation from the current biological age to the biological age of the optimal performance. And that does not mean that we will make somebody who is 80, 20. This is not the calculation in healthy longevity medicine that is needed or reasonable. We are trying to be able to have measurements, and Fyodor and Jan, they spoke about great clocks that can tell us at which point the patient is now and what would be the optimal biological age for that patient. And this is where the physician can get in and help to optimize. That's something that is also only achieved with very advanced AI technologies, not only machine learning, but also deep neuronal networks, federal learning, and so on. But why do we do all that, and how do we stand, where do we stand in comparison to the sick care? So we have the reactive medicine. I think it will always be there. People will get sick. People are born sick. There are diseases that we have to treat. So we have the reactive medicine that is treating diseases, okay. We also have prevention. Another paper that we are writing now is actually discussing the difference between healthy longevity medicine and preventative medicine. Because one can see clearly intersections, but where do we differ, right? So prevention, even the primary prevention, is per se detection of diseases at an early stage, meaning the disease is already there. With healthy longevity medicine, we are trying to actually be able to predict the risk of developing a disease at a specific point of time in the lifespan, and then hopefully mitigate that risk and eliminate it. So one of my mentors said, it's like when you catch the fire when it's very small in the forest, that's prevention. If you detect the smoke, that's longevity medicine. So this is kind of a comparison, and longevity medicine can only exist with two legs. One is diagnostics, one is interventions. And very often I'm being faced with the question, okay, so why do we do all these diagnostics? We have a lot of diagnostic tools now on the market. If there is no proper intervention, under proper intervention, people usually understand, unfortunately, a miracle drug, right? Not existing, no, not yet. And no shortcuts. So the answer is, we need longitudinal data from these diagnostics in order to be able to identify the reasonable and credible biomarkers that will help us then to test those interventions and to see if they are really effective or not and safe or not. So for the diagnostics, as we have seen many times, we have a lot of data that we can collect, going all the way from the omics, multi-omics, through the functional testings, through the imaging, through the epigenetic factors, through the psychological factors, through various things that can be even 150 gigabytes or more. And many clinics do that already, for many years, luckily even. One of the things that I like very much in my practice is to have a whole genome sequencing, and especially getting the so-called polymorphic risk score, meaning not only the mutations that can lead to some problem, but the mosaic, really the puzzle, how the genes are positioned in our genome and how this correlates to a specific risk to develop a disease later on. So I use that a lot, and something that Mariam, Dr. Matar, Her Excellency will like, pharmacogenomics. I also think it's very important both for sick care and for healthy longevity to have this data before a patient would be put on any journey. And of course, plenty of monitoring tools, panels, point-of-care diagnostics, everything that might be used and can be used, and luckily more and more less expensively. So from CGH to mini polysomnographies, to liquid biopsies, to polyneurotoxin, to cognitive testing, and so on, things that we can already apply, and most of us do already apply as longevity physicians. There is always a caution, right? Even with the best liquid biopsies, we can get false positive answers. And this is just an example of a liver test, a liquid biopsy in blood, where a patient was positive in CTC testing. And then we did, so the question is, so what do you do then, right? That's why the physician is needed. What do you do if the CTC is positive? Well, at least you do a DNA liver test, liquid biopsy, to really go even a level deeper to see if that's positive or not, and it was negative here. Also, a physician is necessary to have an individualized granularity of a longevity protocol for a person. Meaning, when do we need which diagnostics, how often, at which level, and last but not least, also to keep it all together in one frame. Another mentor of mine, internal medicine chief in Zurich, said, computers will help us in many things, in oncology, in radiology, but the management of all the fields, the differential diagnostics, something that doctors are trained for through their clinical work, this is something that will be hard to replace. To bring it also then from the differential thinking into a strategic plan on testing, on supplements, on further advanced lab testing, and functional improvements of the people. Last but not least, I would like to mention specifically the brain. It's very important always to remind ourselves that it's not only the body, but especially the most important organ, one of the most important organs for our function. And we have good tools there as well. It's good to have an eye on that. Besides of very good cognitive tests that are very nicely computerized already, neuropsychological testing, it's very important to know that NLP is very helpful for us as well. There are good platforms that can translate data. An easy application tool. For example, we have a patient at an early stage of cognitive decline, mild cognitive impairment, and we usually cannot tell when the patient will go to a moderate level or from a moderate to a severe level. We don't know until it happens, right? So we would like to have tools that will actually predict for us at which point of time we might expect that. And that's already available on the research level. Another thing is predictive biomarkers in the blood. So of course, those are still at the level of clinical testing at the University of Chicago in this point, but it is also coming. So one who is anyway doing blood tests and has a patient with especially a mental disease here in that point, depression and anxiety are extremely prevalent among almost all patients who are healthy, as we would say, physically healthy. This is very helpful also for us to treat those patients at an early stage. And last but not least, something that I like a lot is the quantitative testing. So for all those patients where I would do a brain MRI, and some of them do, we now are able also to use quantitative diagnostic clock to calculate brain age, so biological age of the brain. Fairly accurate, in my opinion. And we know that this type of biological age of the brain determination can help us also to improve the quality of life, to prevent cognitive decline, and several other things that are important for many people, such as focus, memory, ability to learn, agility, etc. Because we know that aging is not consistent and every cell and organ and system is aging at a different pace, the same goes for like functional decline. We decline differently in our functionality of movement, towards thinking, towards seeing, sensorics, and so on. This is why we need very good age clocks. And I will just mention that the clock that Jan talked about, Max co-developed it, would be one of the most important, I think, for the clinical practice, because those are the clocks that actually implement surveys and questionnaires that are objective and measurable in addition to quantitative markers. What we also look forward to is that the biological aging clocks of organs will be very soon validated. So there exist already markers for liver, for specific organs. We know that unfortunately some organs age faster, like ovaries in women, than other organs. So having those clocks and also to understand the correlation of the pace of aging of each of that organ to each other will be very important. Otherwise, we'll go back to the problem that every specialist will look only at one organ, and by helping one organ, you can actually damage another organ. So having the comprehensive correlation will be important here too. And we have a variety of clocks, and Fyodor was talking about them, so I'll just skip them. I just want to mention that I'm also extremely excited about the microbiome clock. I also think that microbiome is one of the most powerful tools that we can actually modify besides of blood age or epigenetic age. And here is just an example of a patient of mine that was followed over several years. I used here blood age as a biomarker, and I was always telling him, I need some objective marker of yours. And you can see that the chronological age was going up, and for me it was important to keep him biologically younger, but not to reverse it, but actually to keep him at a younger optimal level. Interestingly, you can find a lot with those biological ages, not only to know how old am I biologically, is it good or not, or even how is my pace, but in patients who have autoimmune diseases or in patients who suffer with, from fertility issues, patients who have some underlying diseases that you cannot even see very often in the so-called sick care data, you can sometimes detect them very nicely with the biological age. That's something that I wanted to mention. And I think in both worlds, we work with data. Myself in the ICU and in the oncological unit, so I work with cancer patients mostly in the ICU, almost at the end of the life. And I also work with longevity, with very other type of data. What is very important is for us to bring those two worlds together. It's not a separate thing. We want to work together. And I'll just give you examples. So this was a very famous article that came half a year ago or something that was talking about biological age being going up with specific diseases and also with pregnancy, for example, and then going down once the disease goes down. Nothing shocking for the medical society, but it was very influential on the patients. And already in the year 2020, we did a study and actually calculated a score with COVID patients, over 5,000 of them, and saw very clearly that those who had a higher biological age at admission had a much, much poorer prognosis in terms of mortality of COVID. The same we can see also in the new field of so-called geroncology. Doesn't mean for cancer patients that they cannot profit from longevity diagnostics. So this new field of geroncology also is giving us a good tool. And as you can see here in Switzerland, we even developed a flow on how to treat patients, how to diagnose their biological age right at admission. It's very helpful for the triage and for individualized patient treatment in cancer care. The same even in the pancreatic cancer. So in my cohort, about 10,000 patients, we've actually seen that the biological age prediction is very important for their response to therapy and overall mortality. And it differs for males and females. That's just, I'm just always like to differentiate it. I think geroncology will be very important for us because of the senolytic interventions. A lot of senolytics are coming from the field of oncology and vice versa. And all of this is something that the physicians should know. So when we were looking at the gap between research and practice back in 2019, we came up with this publication, Lads and Healthy Longevity, talking about the lack of education. So we created a curriculum for physicians, but it's of course also open for anybody else, that developed to this longevity education hub. You can find it online on longevity.degree. It's for free. It always was. But doctors who are practicing doctors can even get the certification of the American Medical Society. And already 6,000 doctors and more from all over the world took it. And with this, I would like to thank you. I think it's great to live in a longevity ecosystem, and maybe we can take the questions later on.